There's actually data that shows that the highest risk factor for having an adverse event occur to a patient in the hospital is being cared for by a cross-covering physician. I was trying to get data on how many handoffs happen in a day. The closest I found was from 2006, where they said there were about 4,000 handoffs a day, but I think that's a gross underestimation now, so I couldn't even get myself to put it on the slide. But I did look up it in AHRQ. They estimate that there's about 35 or 36 million admissions a year in the health system, in the country. And that translates to about 450,000 inpatients at any given moment every single day. So if you think that even only 20% of them, let's say, have a nighttime physician, that's like 112,000 people being covered by a covering physician overnight, with a very strong risk factor of having something bad happen overnight. So it's no surprise then that preventable medical errors are believed to be the third leading cause of death, probably now fourth leading cause of death in the United States, and JACO reports that 70% of preventable medical errors are related in some way to communication failures. And of course, we have to do better then, right, in our communication failures. And I tell teams all the time, everyone makes mistakes. We're human. This is not an exact science. The key is, what can we do to prevent avoidable mistakes that hopefully shouldn't happen? Those numbers, really are just the tip of the iceberg. They're the ones that get reported. I think most of us have experienced near misses and things that we just tolerate as the status quo. I would challenge each of you to think about the last time you got sign out from someone. How many times was there something that you thought or you found out later wasn't actually the case, or was mistyped, or was outdated, right? Those are all potential errors that you might end up making decisions off of, but they happen all the time, not because someone's negligent. It's just, it's not easy enough to do the right thing for our patients. And really the true magnitude of the problem is much greater than any of us knows, and that we can see. So when I was actually just finishing residency and getting into this work, there was a lot of focus on handoffs with the Joint Commission and the WHO and Institute of Medicine, saying that we really need to improve handoffs, that they're a big patient safety issue. ACGME and CLEAR both have requirements around handoffs and teaming. I love the word teaming because it really is about how do we as a team take care of patients. But I think the pendulum has kind of swung. So when I was teaching about this originally in 2007 to our interns, I would go through what we just went through in terms of why handoffs are important, and everyone was wide-eyed and like, wow, this is really important. To the point that I actually stopped teaching the beginning slides of why it's important, because everyone knew. Like a few years in, I would ask and everyone would say, yeah, we've gotten teaching about this, and everyone kind of knew like this is a really big deal. And now I think we're kind of back where we started, where people aren't, at least what I'm seeing is a lot of people aren't getting taught about this in medical school. And it's kind of gone back to like, yeah, it's just hard to get them done right. It's hard to change practice. And so people just kind of accept things as they are. So I've actually now started going back to these slides and saying it's really important that we pay attention to this. And a common reaction that I get from interns and residents, but especially interns when they start, is this fear, right? Like, what if I make a mistake? And what the message I try to share with them really is that that is a totally natural fear. In fact, I think I had nightmares every night my first year as an attending, because I had the same fear once I was an attending and out of residency, but it's totally natural. And like I said, we all make errors. The goal is to try to avoid the preventable ones and to have a plan about what to do if you're worried about them happening or if something happens. So it's very important that there is a clear process and clear messaging to the residents and interns that, look, if you're worried about something, speak up. If something happens, speak up. Here are the people you can talk to. And there's no blame, no fault, right? This is just, we want to help make things better. And if you come to us, then we can do that together. All right, so now we'll kind of shift into talking about how to do handoffs well in general concepts. Hopefully I've sufficiently convinced everybody that, and you're here because you believe they're important. I'm going to present concepts of like general handoff practices, and then how to do things specifically from a written and a verbal perspective. And then I will kind of pair that with how we've done it within our platform at Penn. But I want to, again, point out that the point isn't Caroline or our tool. The point is really, how do you do this well so you can take these teachings back to your institution? and hopefully implement something that's helpful there. So from a general perspective, we talked about this in that video, is you want you want a place that is quiet and ideally at a computer. Even if you're using a paper handoff system, I think it's really important to be at a computer, because a lot of times there's questions like, wait, did that lab come back? Did I place the order? What time is this going to be? So being in front of a computer, if you can, when doing handoff, is really helpful, because you can kind of quickly look those up, unless of course it's baked into your handoff tool, which is even easier. You want to minimize interruptions. The guidance I usually give is that if you have to, so first of all, I kind of empower the intern to say, it's okay to not answer a call during sign out. It's also okay to pick up a call and say, I'm getting sign out, can I call you right back? And then of course, sometimes they don't feel comfortable saying that, particularly if it's an attending or a consultant. And if they have to take the call, then take the call. But then if it ends up being a long conversation, honestly, anything more than 10 or 15 seconds, then I advise them to start the patient over. And I'm sure each of you have been in that situation where you get interrupted and you just breaks your flow, and then things end up getting missed, particularly when it comes to trying to do things in a standardized way. So you want to standardize your content and format for all patients. This one is extremely important, that if you're worried about the patient, that's the first thing that you should say. This is Mrs. Jones, I'm worried, because it totally clues the receiver in to listen more, ask more questions. Review every patient. A lot of times there's people just waiting for placement. I still at least give a 1-sentence review of that patient, because things happen in the hospital, even when we don't expect them to. I actually added this one just a few years ago, which is that as the giver, I would really recommend either on the computer with your mouse or on paper with your finger, pointing to what you're talking about and highlighting the text that you're actually saying, because there's so much information for the receiver. If you can kind of focus them in on where you are on the page or on the screen, then it helps them, have both a visual and an auditory element to what you're talking to them about. And then ask for questions, encourage repeat backs at the end. So you want to avoid non-standard abbreviations. This goes back to that egocentric heuristic I mentioned, which is that in small groups, you might be used to certain abbreviations, but broadly, they can cause problems. So, we've had situations where MS was written for multiple sclerosis, mental status, and morphine sulfate, obviously all very different things. And one thing I'd encourage you guys to think about is to actually open your handoff to all disciplines and all providers. We did that, I think probably about 7-8 years ago now. And it really, it was kind of met with some trepidation up front, where people were like, I don't know if I want everyone to see my handoffs. And we countered and said, look, we're all on the same team. It's the patient's team. A lot of information is lost in translation between teams. So having access to each other's lists is really helpful, and ends up wasting a lot less time. So we actually implemented our process before IPASS came out, but it was great because they very much match. So I usually teach using IPASS as a framework. The thing I want to leave you all with about IPASS, and we'll talk in more detail about how it's structured, is that it's more than just a mnemonic. And that goes back to the framework about people, process, and technology. The way that one of the ways they got their 23% reduction in errors is the way they implemented it was an entire institutional-wide culture change. They did a widespread education of all faculty, all staff, and students, systematic observations and feedback, in addition to the standardized format and the mnemonic. So, without buy-in from hospital leadership to do that as a big, strategic goal, it can be hard to get some of the same metrics, but at least working with education, feedback, and then standardizing your format is a big step forward. The P specifically in IPASS, I think is not very clear when you just look at patient summary in this list, but the way the IPASS team actually describes the patient summary is really the meat of the handoff. And specifically, it's supposed to be a summary statement, the events leading up to admission, hospital course, and ongoing assessment by problem or diagnosis, and then the plan by problem or diagnosis, which is a lot of information, a lot of duplication between what we write in our progress note already. And I think honestly is part of why we struggle so much with having updated information in our handoffs and our progress notes. Again, to do a separate talk on how we combined our handoff and our progress note workflow. so that you don't have to write the same thing more than once. But the reality is that it's really hard when you don't know a patient to learn them by reading 20 different progress notes. And so that's the purpose of having this summary information in the handoff, so that a covering provider can quickly understand what are the things I need to know about the patient, and importantly, to give them context of any tasks that need to get done based on the problems that you're treating them for. So going through each one, illness severity, sick, watch or not sick, the way we implemented that in our platform was with an actual button to make it really easy and very clear, like this person is sick or this person is a watcher. And it changes the color. You can easily identify who made them sick. On paper or in it like a EHR handoff tool, the way we do that is we write sick next to the patient's one-liner, or you can have a whole separate box for it. I encourage making it very easy to see, very big, and also that anybody can write it. So the way we've implemented it is that the attending, the resident, the intern, a student, a nurse, or a therapist, anybody can, identify someone as being sick and share that with the entire team, kind of like in the airline industry where anybody can ground a plane if they're worried about them. And then code status should always be on the handoff. And what I mean by if not full code is you should verbally talk about it if it's not full code. It should also be very clear visually if someone is full code versus not full code, or if the code status is not there, so that you can kind of easily see what needs to be filled in. A lot of these things are, how do we make it easy for us to do the right thing and not make mistakes? So I've reorganized the patient summary, I think, into something that is a little bit simpler to think about. And in the way I organize it is just two things. You have an updated summary, like 1 to 3 sentences of the, what brought the patient to the hospital and their diagnosis or their symptom. And I'll give examples of that, but not an entire chronological history of what has been happening for the patient, just very short. Then you go through the plan by problem. And within each problem, then you can talk about the current status of the problem, what the course is that has been happening for that problem, what the current plan is, and then any relevant data and medications. And I encourage putting action items or tasks within the problem. So the reason why we ended up we used to have it all separate. And the reason why we combined it into problems is because when we would teach people, interns, when they would come in and we would go through a simulation, we would actually have them write out the handoff and then do a verbal handoff. And every single time, the most intuitive thing for people to do when they would start is they would talk about a problem and then talk about the tasks with the problem, talk about the problem and then talk about the tasks. And so it felt really arbitrary and unintuitive to separate the problems and the action items. So if you put them together, then it gives you context about why you're doing those tasks, and it helps make it more intuitive as you're going through the handoff. And then, of course, you have the situational awareness or FYIs of the things that we need to that you want to alert the team about, and then the synthesis by the receiver. So we'll talk about these in a little bit more detail. I don't know if any of you know Dr. Dukoski. She's a former colleague of mine. She's now at UPMC, but she came up with this really wonderful framework called the 3 R's and 3 W's for how to organize your plan by problem. This is applicable for progress notes. It's applicable for discharge summaries. I find it very helpful, both for doing, but also for teaching. So the way this kind of works out is the 3 R's are reassess. So update your assessment statement or your one-liner on a regular basis. Rename your problems, meaning is it shortness of breath or is it now community-acquired pneumonia? So you want to always be updating the problem names once you understand them. And then reprioritize them. So you might have, abdominal pain as your number 1 problem, and then you realize on day 2 that your patient is septic. Well, sepsis should go to the top of your list. So reprioritize the problem so we know what's the most important thing we need to see about the patient first. And then the 3 W's are for within each problem. What is the problem? What is your assessment of the problem itself? So if the problem is diabetes, what is your assessment? Is it controlled? Is it not controlled? Is it getting better? Or are we having to change medications or not? And this is, I think, one of the most important is, why do we think the patient has this problem? And usually what I see people do is skip straight to the what next. But if we take a moment and focus on the why, this is what we learn in medicine, right? Is to think about why we think this problem is happening and what we need to do about it. But really making sure that we say, why do you think they came in with DKA? Why do you think they came in with hypertensive urgency? Why are you not treating the anemia? What was it that made you think that it was okay? And there's plenty of reasons to not treat it. But knowing why really then helps the receiver team, whether it's at night or the next service block of people coming on, makes it a lot easier for them to understand, how to pick up where you left off with the patient. And then what next, right? What are the things that you need to do to carry out the plan or to treat this particular problem? Okay, so some other general recommendations about the patient summary. Cleaning it up and updating it regularly are extremely important. So I have seen pages and pages and pages of signouts for one person, and it becomes so hard to find what you're looking for. So as much as possible, deleting information that's no longer relevant. What we built into our application was the ability to archive, because what we found, I tried to get people to delete forever. And I realized no one wanted to delete because they didn't want to let go of it. They wanted it easy to find. They wanted to make sure that if someone asked them a question, they knew where to go. The problem is it makes it confusing for everybody else. So we made this function, or this ability to just archive information, where you just kind of flag it and say, this is old, or archive, archive, archive. It hides it. You don't have to look at it, but you can easily get to it. So that if you're, you don't want to delete it because you think it could be helpful, then it's there when you need it, but you don't have to look at it all the time, and it doesn't clutter your space. Obviously, if you can't build a tool that lets you archive it, then I would say, kind of moving information to the bottom of the column or the bottom of the section and saying, old information about this problem or old information about this patient. But the key is you want it to be really easy to get to the meat of the issues that you're currently working on for a patient. And then from a tasks perspective, there's so many tasks we're working on. You want to separate them into what you're managing as a team and what you need to have the overnight person manage. But importantly, also discharge planning tasks. So we always kind of mark them. Well, on paper, we would separate a different section and say, these are the discharge tasks that need to happen. Believe it or not, this is important for Handoff, because overnight all the time, family would come in and say, well, what's happening with this? And what are we going to do in a week? And so the on-call person has to answer a lot of those questions. Having it clearly identified is really helpful. Whether it's separating it into a section or flagging it is great. Does someone have a question? Okay. All right, so the way the 3 R's and the 3 W's then can play out. So imagine, instead of having separate columns for your problems and for your plan and for your tasks, as I said, we put it all together by problem. And the way that works, and is you have your problem, which of course should get renamed as you get more data. I'm just going to, I think someone might need to mute, but I can't tell who it is. Okay, so you want to rename your problems. Then you have your plan, the what and the why of what's going on for the problem, and then the what next. So thinking about what needs to happen for that particular problem, which gives context to the receiver. So when you're actually doing a verbal handoff, how does all of this translate? So again, starting with the name of the patient and that you're worried about them. Use a sick button if you have it, or write it, but just saying very clearly, this is Mr. Smith and he's very sick, or this is Mrs. Jones and I'm worried about her. Talking about the talking about the code status if it's not full code. So saying, he's DNR, DNI, and these are his particular wishes, any kind of qualifications that are there or sensitivities, to talk about them. I think it's really important, especially these days, to talk about family and what their wishes are in terms of conversations with the patient. So there are some families who are like, I'll talk to you in 3 days, right? But there are other families, we've all worked with them, who are like, I want to know every single thing that happens at every single moment. That would be me. So we just want to make sure that we tell that to people overnight, so that if something happens, they know when to call and who to call. And it should be very clear who is the main point of contact. So again, having a separate place or a very standardized place where you always know this is where I'm going to find contact information for the patient is really important. So then you have your summary statement. So the first part of the patient summary in IPASS, start with the chief symptom, update it once you have more information, this can go on and on. Honestly, it could be one sentence and it could be 10 sentences. I try to challenge people to keep it to no more than 5 sentences. But, really it should be concise. It should only have relevant past medical history and then major events that have happened. So this is an example. Mr. Joe, 89-year-old male who came in with a history of peripheral arterial disease and hypertension, who presented with left arm weakness, but now found to have an MCA stroke, also with AKI and AFib. Now I'm going to go through the rest of his plan by problem. And that's then how you can go through it, instead of chronologically going through how you diagnose the AKI and AFib. When you get to the problems, talking through the active ones, again, the what, the why, and the what next. I usually recommend keeping the chronic problems grouped at the bottom so that they're not kind of cluttered in with the active ones. But it is important to have them. Like you might, something might happen overnight, or a question might come up about, a remote issue. At least knowing that it's there and having quick access to it is helpful. So we would find a lot of people cutting and pasting entire radiology images or entire pathology results into handoffs. I find that very overwhelming. There's kind of a balance, right? Like we want to teach people that you should read the whole study, you should read the whole report, not just the impression. But for the purpose of a handoff, you want it to be concise and really limited to what's important. How is it going to affect your interpretation of that problem, and summarize it, and then clean it up. So again, either delete it, move it somewhere, or archive it if you're able to archive it so that it hides and you won't see it on a regular basis when your history is collapsed. For medications, the main guidance I give people is you want to make sure that you verbally review high-risk medications. So antimicrobials, anticoagulants, pressors, narcotics, benzos, the ones that have the most issues that come up overnight. And again, you want to do it within the problem, right? Are they on warfarin for a PE or for AFib or for something else? And then you want to mention any important changes of medications. So things that are new, things that are discontinued, or things that you've recently changed. The way I see this most often is with metoprolol or Lasix or something where you're managing, someone's rate or a rhythm, and you're titrating the dose. You want to let people know we've been titrating, and we reduced the dose this evening. So you might want to try something else if something comes up, or change the dose back. So giving them that guidance. The key is, we want our colleagues to be able to make decisions as we would if we were there. And then with the action items, I want to make it very clear to discuss every single task that needs to happen, right? Because you need to have both the verbal and the written communication about the tasks, why you're doing it, and what to do based on the results. So an example, follow up on a 7 p.m., not just follow up panel, it would be 7 p.m. panel. Why is that he's hyponatremic? We think he's pre-renal, and then what to do with the results. Increase the IVF if the sodium's still lower than 130. It should be really easy to see when a task is completed. So on paper or in a free text world, you can, when you make your brackets for your checkbox, you can put an X in it to say it was completed. The way we built that in our third tool was to actually make it a checkbox that you can check off and you can easily see that it's done. You also want to make sure you can tell who completed it and when. So if there wasn't an issue, then you can talk to that person and figure out what the problem was. Every task should have an actual separate line item, because otherwise things get missed when you group them together. People visually are looking for a bracket or a checkbox. So each, like the post-cath check should be separate from the check I's and O's. And then being very specific. So I noticed especially early interns tend to say things like, try to check if you can, and it would be great if you could do X, Y, Z, because they feel bad. But the reality is if it needs to get done, it needs to get done. And if we're vague in our language, then people won't really know if we want them to do it. And if it doesn't need to get done, then we don't sign it out. So these are examples from some paper sign-outs that I found and how to make them better. So give specific, like instead of just signing out a 6 p.m. CBC, like in the example from the story in the beginning, you want to give specifics. What are you looking for in the CBC? What is your transfusion threshold? What would you anticipate needing to give? Oh, sorry. So this one was INO check at 2300, would like him 500 to a liter negative at least. So that's great. They at least gave their INO goal. But you've probably, as the primary team, already been managing his Lasix. You already know, am I going to give him 20, 40, 80 milligrams of Lasix? So instead of making our colleagues go and look through all of the orders and try to figure out, just tell them, give him 80 of Lasix. And then If you are giving guidance that you might need someone to start antibiotics, then again, give what you would like them to start, any preferences. Again, most likely this is something you've already talked about as a team during rounds that morning, so might as well share that information, or at least make sure it's very clear in your progress note for the receiver to read. For situational awareness or anticipatory guidance, you want to try to anticipate things that will happen overnight and write them in your handoff or identify them as FYIs. And sometimes these are just things that people tend to get called about every night for a particular patient. Just write them and say, FYI, these are things that someone's been getting called about every night. This is what I would do. Or you can say, with specific guidance, if the temp is greater than 100 and 1.5, would check blood cultures again and start empiric bank. Or maybe your patient's already on bank and you said, well, if they're still spiking, we're going to double cover with meropenem, then write that. So make it very clear so that the on-call person can carry out the plan that you had in mind for them. So we want to make it very easy for people to see what are the tasks that need to happen for a particular patient. And sorry that I think the background slide is a little busy here, but seeing very clearly, a one-liner summary or the quick summary, the ability to get more data if you want, but then, what are the tasks that are happening for the patient either during the day or at night, and coupling that with any FYIs. We actually changed the wording here. So we used to say primary team and covering team or cross-covering team. And we made the decision to change it and say it's actually day and night. And the reason why we did that was because we really wanted to, again, change the attitude around how we think about working on patients and saying we're all on the same team. So it's not something I have to do versus someone else has to do and saying I'm just covering. It's actually this is what needs to happen for the patient, regardless of which team you're on. So let's write it that way. We found that it was really important to have the ability to view all the tasks that need to happen for everyone on the list for handoff, so that you weren't like flipping through pages and pages and pages of information. So it's kind of a condensed version of this, where here you can see, if you wanted to, you can look at the clear tasks, you can see day tasks, you can see everything, but this is one person at a time, but then you click through to see the next one. Versus here is in one view, you have all your patients, and it's just your handoff view. So I see the one-liner, I see the FYIs, I have a place to put events if I'm the night person or the day person of, hey, these are the things you need to know happened during the day or during the night. And then a place specifically for tasks that need to get done by the night team so that they can easily do that. And then this was actually not something I had thought about, but we got feedback from users and built it, which was very cool. So, and actually it was more from surgery, but medicine now uses this a lot also, that they wanted a combined, they called it a SCUT list, and we just call it the task list, but they wanted a combined list of for, everyone, all the different teams I'm covering, what are the 5 things I need to do? So basically a combined list of all the tasks for everyone on the list, just so I can, keep track, okay, these are the 5 check boxes I need to do. So we built that where you basically have everything grouped for everyone on the list, what needs to happen during the day, what needs to happen at night. You can move them to later, but right now there's nothing there. Again, you can check them off and you can sort them by time. So, if for 10 different people, you have something at 7 p.m., something at 10 p.m., something at 11 p.m., it gives you a consolidated list of these are the things I need to do in the order I need to do them.